Hi guys, welcome so much to Dr. Krishnan Lecture. This is a channel dedicated to make learning easy for all the medicos and create an amazing community of super awesome people like you. Regards, CEO and founder of Dr. Krishnan Lecture, Dr. Ramesh Krishnan.
In this lecture video, I will discuss about approach to muscular dystrophy. The content of my lecture include negative and positive symptoms and signs of muscular dystrophy, durations of evolutions of muscular dystrophy, distribution of weakness of muscular dystrophy, precipitating factors of muscular dystrophy, associated symptoms and signs of muscular dystrophy, diagnosis of muscular dystrophy based on pattern of inheritance, investigations in the patients with muscular dystrophy. Now, we should look for the precipitating factors while we are investigating a patient with muscular dystrophy or myopathies. If the patient presents with weakness, pain or myoglobinuria provoked by exercise, the cause can be because of glycolytic pathway defects. If the episodes of weakness is associated with fever, it can be because of carnitine palmitoyl transferase deficiency. Paramyotonia congenita, the cold exposure precipitates their symptoms of muscle stiffness. The cold exposures precipitate the symptoms of muscle stiffness in the patients with paramyotonia congenita. Then drugs that can cause toxic myopathies include, if the myopathies are non-inflammatory, necrotizing or vascular, it can be because of alcohol, cholesterol lowering agents like statins, chloroquine, colchicine, cyclosporine and tacrolimus, as well as vitamin A analogs, isoretinoic acids. If the myopathies are inflammatory, the causes include cimetidine, D-penicillamine and prokienamides. If the myopathies are associated with rhabdomyolysis or myoglobinuria, the causes include alcohol, amphetamines, cholesterol lowering drugs, cocaine, heroin and toluene. If it is associated with myosin loss, the causes include non-depolarizing neuromuscular blocking agents and steroids. Now, we should look for the cardiac diseases which can be associated with myopathies. If the myopathies are associated with arrhythmia, the causes include Anderson-Tawil syndrome, Karen-Sarin syndromes, muscular dystrophy with myotonia, limb girdles 1B, 2C, 2F, 2G and Emery-Dreifuss. In these cases, myopathies are associated with arrhythmias. If myopathies are associated with congestive heart failure, the causes include acid maltase deficiency, carnitine deficiency, muscular dystrophy with Duchenne, Vickers, Emery-Dreifuss, myotonic, limb girdles 1B, 2C, 2F and 2G, as well as Namelin myopathies and polymyositis. In these cases, myopathies are associated with congestive heart failure. If myopathies are associated with respiratory insufficiency, if the patient presents with respiratory insufficiency and has myopathies having the features of myopathies, then the causes include Vickers muscular dystrophy, Duchenne muscular dystrophy, Emery-Dreifuss muscular dystrophy, congenital myopathies, centronuclears and limb girdles 2A, 2I and facioscapulohumeral dystrophies. Metabolic myopathies that can cause respiratory insufficiency include acid maltase deficiency and D. Brancher's deficiency, mitochondrial myopathies, and inflammatory myopathies in the form of polymyositis. On examination, if the patient is having hepatomegaly, it can be because of acid maltase deficiency, debranching enzyme deficiency, and mitochondrial disorders, cataract, frontal balding, and mental retardations is associated with myotonic dystrophy. If myopathies are associated with rash, it can be because of dermatomyositis. Then family history is also important in the diagnosis of myopathies, and diagnosis of myopathies based on pattern of inheritance include X-linked disorders is most because of Baker's muscular dystrophy, Duchenne muscular dystrophy, and Emery-Dreifuss muscular dystrophy. Autosomal dominant disorders include central core myopathies, facioscapulohumeral dystrophy, limb girdles muscular dystrophy type 1, oculopharyngeal muscular dystrophy, myotonic dystrophy, paramyotonia congenita, periodic paralysis, and Thomson's disease. Autosomal recessive disorders associated with myopathies include Baker's myotonia, limb girdles muscular dystrophy type 2, and metabolic myopathies. And maternal inheritance in the patients with myopathies are because of mitochondrial myopathies. Now we should look for the investigations in the patients with myopathies. Differential diagnosis of CK elevations include myopathies that can be associated with creatinine kinase elevations, dystrophinopathies, chylomyopathies, drugs and toxins induced and inflammatory myopathies, neuropathies that can be associated with creatinine kinase elevations include Charcot-Marie-Tooth disease and Guillain-Barré syndromes. Motor neuron disease that can be associated with CK elevations include amyotrophic lateral sclerosis, post-polio syndrome, and spinal muscular atrophy. Idiopathic causes include hyperkalemia, increased muscle mass, hypothyroidism, and hypoparathyroidism. In these cases, myopathies are associated with increased creatinine kinase elevations. EMG study, electromyography, and there can be different pattern of inheritance. If in EMG, myopathic motor unit potential is associated with fibrillations, the causes include inflammatory myopathies with polymyositis, dermatomyositis, infectious causes of myositis like viral and parasitic, drug induced like penicillamines and statins and sarcoids. This EMG is a patient of polymyositis. Here in this case we have the complex repetitive discharges. In B there is fibrillations with sharp waves. C showing short durations motor unit potential with rapid recurrence, and D showing long durations polyphagic motor unit potentials with reduced requirements in chronic stage. If myopathic motor unit potential is not associated with fibrillations, then non-inflammatory and non-necrotizing myopathy could be the cause, with endocrine myopathies, congenital myopathies, mitochondrial myopathies, metabolic myopathies, toxins myopathies, oculopharyngeal dystrophy, facioscapulohumeral dystrophies. This is the EMG in the patients with hypothyroidism. Here we can see myopathic patterns of motor unit potentials without fibrillations. If myopathic motor unit potential is associated with myotonic discharges, the causes include myotonic dystrophy and carnitine myopathies. If myotonic discharges are without myopathic motor unit potentials, the causes include paramyotonia congenita, myotonia congenita, hyperkalemic periodic paralysis. If myotonic is associated with complex repetitive discharges, the causes include metabolic myopathies like acid maltase deficiency, deep branches diseases, and glycogen storage diseases. This is the EMG in the patients with myotonic dystrophy. Here B shows myotonic discharges, speeds with initial sharp positive waves followed by slow negatives.